In this lesson on anxiety, we're going to introduce the concept of anxiety, which you'll see on subsequent lessons is reused. Everyone has felt anxiety at some point in time, and if you're wondering if you have, think back to when you opened up your envelope or clicked the inbox for your MCAT score. You had that thought of, maybe I shouldn't open this email. That sinking in the pit of your stomach, or the short of breath that you might have gotten, or a little bit of tachycardia. And that's not true anxiety, but that's the sensation of anxiety, that vague sensation that something is wrong. Everyone's felt it. Anxiety is going to come up a couple of times in different disease states. Sometimes it will be driven by stimulus, and sometimes it will be relieved by an action. In this lesson, I want to introduce anxiety as a concept, and then talk about two major diseases opposing one against the other: the chronic generalized anxiety disorder against the acute panic attacks, and finish off with phobias. Let's start off with anxiety in general, and that's what this whole lesson is going to revolve around. So the sensation of anxiety is really difficult to pinpoint, and one person's expression of anxiety may not be like another's, but often it is congruent or consistent inside that one person. One person's anxiety is felt the same way in that person every time they feel anxiety. And it comes in two parts, sort of the mental feeling you get, and then also the physical symptoms you might experience. The things you might think of are worry, fear, or hypervigilance. And the physical symptoms you might experience are going to be things like palpitations, perspiration, dyspnea, or chest pain. All those things you feel on the first date as the door opens, or you see your date sitting there at the restaurant. A little anxiety is okay. A lot of anxiety is not. Some generalities about anxiety disorders: most of the time, and I will note exceptions in the future lessons, women suffer from anxiety more often than men. And usually anxiety disorders are going to set in teens and early 20s. And the patient doesn't like it. They know they have anxiety. It's uncomfortable. And because of that, they may develop with it mood disorders. And if they're going to get a mood disorder, it's usually depression. And because that sensation of anxiety is uncomfortable, they may not know it's anxiety, but they know how to control it. They may self-medicate with alcohol. All right, so that's sort of anxiety in a nutshell. Let's tackle first generalized anxiety disorder and compare it to panic attack. Generalized anxiety disorder. Right. Generalized. The pathology is going to be a chronic, low-level, insidious amount of anxiety. And that's the key here. Generalized anxiety disorder is chronic. It's a low level of anxiety all the time about most things. And so the criteria to meet generalized anxiety disorder is a constant state of worry, that is about most things on most days. There's also a timing component that is at least 6 months in duration, and must also involve somatic complaints. Somatic complaints can really be anything: fatigue, change in sleep, change in weight. But where I want you to look at it for the test, because it's so obvious, because it's so impairing in someone's life, are going to be things like sleep change, changes in weight, irritability, and concentration. It's not just that they worry about things, it's that it impairs their ability to work and interact with others. It becomes an impairment that makes it a disorder. The diagnosis of generalized anxiety disorder is clinical. There is no test. The treatment, because it's chronic, because it's around all the time, they're feeling it most days, most of the time of most days. Psychotherapy is going to be way better than medications. You can teach the person to deal with their anxiety. Now, both these disorders, generalized anxiety disorder and panic attack, have no specific triggers. But generalized anxiety disorder is going to be someone who worries about most things most of the time. Now, of course, if you actually have to worry about them because they're significant for survival, it's not generalized anxiety disorder. If you can't have enough money to feed your children, turn on electricity, and house your family, that's not anxiety, that's real true worry. But what you're looking for is going to be the person who's worried about making it to the post office on time, because if it doesn't get to the letter, it's going to take 2 weeks to get to their mother. They won't be able to get to the school to pick up their kid on time. They don't pick up the kid at school on time. They might have to pay extra, and then be coming back and be late paying for the parking tickets. It's a worry about most things most of the time. But because they experience that all the time, the chronic nature makes it good to use psychotherapy to target it. The medications you'll use to help patients with generalized anxiety disorder, because it is a chronic disease, are the chronic meds, like SSRIs. You can also use buspirone. People with generalized anxiety disorder might have panic attacks. Panic attacks are aborted with benzodiazepines. But I want you to learn, because it's a chronic disease, psychotherapy is better than meds, and chronic therapy with medications are better than the acute. Don't prescribe benzodiazepines to someone with generalized anxiety disorder because they'll become dependent on them. Generalized anxiety, let's compare it to panic disorder. Panic disorder, in comparison, is going to be acute, overt, and catastrophic. The thing about panic attacks is that they come out of the blue. They're not provoked. There's nothing that triggers them. They just happen. So they can be very debilitating. We used to use only the panics part of this mnemonic. But it wasn't inclusive enough, so we added students. Students, panic. Now, a lot of these are kind of forced to make the mnemonic work, but I want to show you that panic disorders can present like any other significant medical disease. The S stands for shortness of breath. The T is trembling, and U is unsteady. See how those two go together. D is depersonalization. We'll learn more about that in the dissociation lesson. E, forced to fit, as excessive heart rate or tachycardia. N is numbness, that goes along with T, tingling. S is sweating. Panic is P for palpitation. A is abdominal pain. N is nausea. I is intense fear of death, a sense of impending doom, and C is chest pain. Now you might look at some of these and see dyspnea, tachycardia, diaphoresis, palpitations, nausea, sense of impending doom, chest pain. And these are all the things that people use to describe medical disease that could kill people. So unless the person has diagnosed panic disorder, the first thing you want to do is rule out those diseases. You want to rule out acute coronary syndrome. You're going to do that with an EKG, troponins. You want to rule out hyperthyroidism, too much T4, by screening with the TSH. And you want to rule out asthma, generally because the person will have a history of asthma or they will be wheezing. The thing is, especially when it comes to the MI, a person who has a myocardial infarction can be young, healthy, and in their 20s. But that means they have some undiagnosed thing you didn't know about. Most of the time, people having MIs are older hypertensive diabetics. So the panic disorder will look like an MI, only remember, in their 20s, women, and they have no medical history, no reason to have that infarct. Panic disorders are acute and catastrophic. So the treatment is going to reflect the acuity and the severity. In this case, medications are better than psychotherapy. Because it's acute, you're going to use benzodiazepines. You're not going to prescribe them chronically or long-term. You use the benzos to abort the panic disorder. And while you can use chronic medications like SSRIs to reduce the frequency of panic attacks, what I want you to learn at this level is that Panic disorders are acute, use benzos. Don't use SSRIs. Generalized anxiety disorder is chronic. Use psychotherapy and SSRIs, don't use benzos. But panic disorder psychotherapy still works. It comes in the way of cognitive behavioral therapy. It's another way out of the panic attack without using medications. You train them certain things to do or act in order to abort the attack. Panic disorder must be modified with something else. It's either with or without agoraphobia. Agoraphobia is the fear of going outside alone, being in large crowds, or taking public transport. You can imagine that if a panic attack is this debilitating, and it can occur without a trigger, out of nowhere, out of the blue, well, there might be some fear of it happening in public. So patients might experience agoraphobia along with panic disorder. So before we move on to phobia, I want you to see generalized anxiety disorder as the chronic insidious disease treated with chronic insidious treatment. Panic disorder as acute overt disease treated with acute overt therapy. And we want to round this out with phobia. What's a phobia? Phobia means fear, yes. But that fear is two things. It is exaggerated or it is irrational. And usually it is both. And it is a fear against a specific thing or a situation. Two types of phobias I want to focus on. One is specific phobia. The other is social phobia. Phobias are exaggerated and irrational. Let's talk about fear for just a minute. Fear is a good thing, right? If you are an ancient human growing up on the plains and you see a large feline predator like a lion eat your family, you should probably fear that lion. And it would make evolutionary sense if you then learn to fear all large feline predators, whether they're a tiger or a jaguar. It might be, though, a little exaggerated if you were attacked at a zoo by a tiger in a cage, but it never really touched you. And then you fear the kitten meowing and purring between your legs. The fearing of the kitten might be a bit exaggerated and irrational. But that's a learned behavior, seeing as your family being eaten by a lion, so maybe that's okay. What's pathologic is when you have this response, whether it's learned or inherent, that you can't control, that you know you're not supposed to be afraid of it. It's irrational. And when you see the thing that triggers your phobia, you get out of control. That's the person who sees a spider and jumps on the chair, even though the spider's walking away, and it's no bigger than a dime. Or it's the person who fears clowns and has to run out of the room when a clown walks in. It's exaggerated and irrational. They know they shouldn't behave that way, but they do, and they can't control it. So specific phobias, I mentioned a few already. Heights and flying are two common ones of situations. And spiders, clowns, and if you're Indiana Jones, snakes. And that's a great example, right? Indy goes around the world collecting artifacts. He goes to places where there are jungles. There's probably going to be a snake. It would hinder his ability to get these artifacts if there's a bunch of snakes. So that fear is both exaggerated and irrational. You can overcome phobias with cognitive behavioral therapy, and there's two forms. The first is called flooding. The second is desensitization. We go over more about this in your notes. Flooding works less well, but works quickly. Desensitization is more long-lasting, it's more effective, but it takes longer. In both cases, you're going to control the anxiety response with medications, usually benzos. Then you introduce the thing that they have a fear to under the calm state. In flooding, you're going to bomb the person. You keep them calm and then overload them with the stimulus of the thing that they fear. Works really well if you got to go to South America and take pictures of spiders if you're a photographer and you have a fear of spiders. Desensitization works by slowly incrementing the amount or severity of the anxiety-provoking thing. This works much better. Picture virtual reality where you put on some goggles and then you go to the first floor, back down. Control the anxiety medication, second floor, third floor, and over many sessions, Eventually you're on the 55th, and you have been desensitized to that phobia. That learned fear response that's so tightly associated with that thing gets broken, and eventually you don't need the controlling meds anymore. We close out because the boards love social phobia. There's two I want you to know about. That's public speaking and public peeing. Don't worry about public peeing. For whatever reason, public speaking always comes up. Use non-selective beta blockers like propranolol or nadolol to help the tremors and the cracked voice. So to review, description of anxiety. Everyone knows what it feels like, but it's going to feel different to someone else than it does to you, but there's some similarities. And to be able to separate generalized anxiety disorder, chronic and insidious, use psychotherapy, against panic disorder, acute, catastrophic, use benzos, plus minus agoraphobia, and be able to identify different phobias and know that use cognitive behavioral therapy to get over specific phobias, and you can use non-selective beta blockers for public speaking. That is anxiety disorders.